Welcome, everyone. This is again, one of our guest faculty research seminars where we have guest faculty present their research and then have discussion about that in global health. Today, we're honored to have Gilda Sedge give our guest faculty research presentation and discussion. I'm going to introduce her quickly. Dr. Sedge was a principal research scientist at the Guttmacher Institute, where she forged collaborations that led to the Institute's designation as a World Health Organization collaborating center. Her areas of expertise include the reasons for contraceptive non-use in developing countries, trends in the incidence and safety of abortion worldwide, self-managed care in sexual and reproductive health and rights, and innovative methods for studying clandestine abortion. Gilda has conducted original research in Burkina Faso, Senegal, and Indonesia, and I'm sure I've maybe missed other places. She's currently leading a consultative process for establishing a research agenda on self-care in sexual and reproductive health rights. She's on the editorial advisory board of the Lancet Public Health, and she co-chairs the Self-Care Evidence and Learning Working Group hosted by Population Services International, PSI. She received her undergraduate degree from the University of Pennsylvania and both a master's degree in Population and International Health and a Doctor of Science degree in epidemiology from the Harvard T.H. Chan School of Public Health. So thank you. It's hard to do a brief introduction of Gilda, but I'm going to turn it over to you now, Gilda. And please, you probably tell us more about yourself, but also tell us what research you're working on.
I will. Thank you for that kind introduction. It's great to see everybody here. I've been enjoying getting to know about Rutgers Global Health Institute, and so I will take a minute and give you a chance to get to know me a little bit better with a few notes that maybe go beyond Rick's description. And I'll start with how I came to be in this profession in the first place. My parents are Iranian. I was born about 10 months after they got here. I was very much an accident, and I saw my mom finish her high school equivalency while I was in the first grade, and I saw her transform herself and what it took to kind of catch up. And that's part of what inspired me to get into research, because I have a mind for research, but on sexual and reproductive health. Dr. Morling already reviewed my training. I would describe my master's degree as having been in demography light, and my doctoral training in epi and biostats. I've had the opportunity, I've been lucky to have the opportunity to apply all of these to my work. I've spent about 15 of the past 25 years at the Guttmacher Institute. And for people who aren't familiar with that, that's an NGO whose mission is to conduct policy relevant research on sexual and reproductive health in the US and globally. And I've spent much of the past 3 years kind of straddling the foundation world with the world of applying evidence to policymaking. These are some or many of the studies and projects that I've led over the past 20 years or so, and I'm not going to describe all of them. The two that are in bright blue are the two that I am going to talk about in this next half hour or so, especially global trends and abortion incidents. Can you see my cursor as I move it around?
I can't.
And okay, so I'll move it around freely for myself. And the two green are those that are in process now, and the gray oval in the bottom right is the work that I would like to do, foresee doing going forward. So I am going to talk about one of my areas of research, which is on the incidence and safety of abortion worldwide. I'll talk about why we study it, how we study it, and then I'll share a few key findings from this work. And this research is meant to inform policy. And so I'll talk about the dissemination of this research to policymakers and to the general public / the voters. And I'll also describe real briefly some innovations that I've been involved in and how we gather new information on abortion. and then the research that I would like to do going forward that builds on this body of work. Feel free to drop questions in the chat. I might not be able to see them, but then they'll be there for, and we are ready to have have a Q&A. I am going to take a pause about 2/3 of the way in, and we can take a couple of questions there too. Dominica has kindly offered to moderate the chat. If there are any questions of clarification that are best asked on the spot, it's okay if you want to go off mute and do that. This map on the right is the countries of the world color-coded according to their abortion laws. So all the countries that are not green are countries with moderately restrictive or very restrictive abortion laws. And you can see that they're mostly in Sub-Saharan Africa and Latin America. Those two parts of the world have been getting greener over the past 20 years. The trend has been in the direction of liberalization of abortion laws. This map is a year old, and it's even greener now in Latin America because of Colombia than it was a year ago. We expect by the end of this year that the US will not be green anymore. I always have to catch my breath when I get to this part of the presentation. So this is just a little bit of background. I know that this is a diverse audience with respect to areas of expertise, and I thought I'd start with describing some of the reasons why it's important to study abortion, including doing descriptive research on the incidence of abortion. And one reason is that abortion is common, and it's a little bit circular. If we weren't doing this research, we wouldn't necessarily know that. But 1 in 4 pregnancies ends in abortion, and many people think it's more rare than it is. This is true globally. It's also true in the US. It's also an important public health issue. Somewhere around 10% of maternal deaths are the result of an unsafe abortion. And even if you're not interested specifically in the study of abortion, it's a factor in pregnancy spacing, studying contraceptive failure rates. So a lot of research questions that people are interested in require evidence on abortion. And it's also, as I think we're well aware, a contentious policy issue. And contentious policy issues need evidence to inform the discourse and the decision making. But it's also hard to study abortion. And why is it hard to study abortion? One, as you just saw, it's illegal in a lot of countries. And in those settings and countries, health systems don't have good information on abortion incidents, either because that's not where people are getting their abortions or because health systems are not recording them as abortions in order to protect their patients and themselves. Even where it is legal, it's often clandestine. So for example, in this country, abortion is legal, but imagine if I asked for a show of hands, how many people here have had an abortion or know someone who's had or actually been in a relationship with someone who's had an abortion. I imagine people would be uncomfortable to be asked to raise their hands if that's true for them. And that's similarly, people often underreport their abortions in surveys. Also, with the advent and increasing availability of abortifacient drugs, which is at the beginning of that era we have referred to as RU486, it's been increasingly possible for people to have abortions outside of health systems. And in some countries, for example, you can get these drugs at the pharmacies. So there's a lot of gaps in abortion data, even where it's legal. So when I first went about estimating the incidence of abortion worldwide, I set about with my research team to collect all the data and study-based estimates of abortion incidents that we could get from as many of the 200 or so countries in the world as we can get them for. And I built up a cadre of knowledgeable informants with expertise in different countries or regions, and we used their inputs and insights to help us make inference for countries without abortion data or adjustments for underreporting. I was fortunate to be able to get colleagues at the WHO to collaborate on this work. They were already estimating the incidence of unsafe abortion, so we're able to put our pieces of work together. And we had our findings published in The Lancet in 2008, and again when we updated the estimates in 2012. About 8 years ago or so, inspired by work I saw coming out of the UN Population Division, I suggested that we kind of overhaul how we make our abortion incidence estimates. So we again compiled all the statistics and estimates we could get of abortion incidence, but this time we also compiled data on the predictors of abortion incidence and input all of these into a multi-level model, more specifically a Bayesian hierarchical model, so that we can make formal inference for countries without data and adjustments for underreporting. And so this time we had to gather evidence for all the countries in the world that we could, and for 25-year period, and now more recently for 30-year periods, so that we could estimate trends over time using this model. I was able to collaborate with WHO again. That took a little bit of effort because there was change in staff there, so we had to forge new relationships. Fortunately, we were successful in doing that, and these findings were also published in the Lancet. So the first step in developing and creating a model, making model-based estimates, was building the conceptual framework that the statistical model was then going to meant to represent. So according to this conceptual model, the number of abortions in a population, and that's the dependent variable, so it's on the left, is the sum of a number of abortions that will be experienced by women who are classified as having an unmet need for contraception. That's basically women who aren't using a method even though they don't want to get pregnant, plus the number of abortions or unintended pregnancies and abortions that will be experienced by women who are classified as having a met need for contraception. Those are women and couples who are using a method, but we take account in this variable for contraceptive method mix and likely failure rates. And then the number, the expected small number that will be experienced by women who have no need for contraception. And that includes, for example, women who are perfectly willing to get pregnant. In each of these subgroups, the probability of getting pregnant is a function of a woman's and a couple's fecundity. That's their ability to get pregnant, and of how often they're having sex. And then among those who get pregnant, the probability of having an abortion is a function of how motivated she is to avoid having a child and how able she is to act on those preferences. So for example, her access to safe and legal abortion. So for each factor, we needed to get a variable that represented it, that had, for which we had values for every country in the world, and also for every year, for a 25 and then 30-year time period. If we didn't have values for that variable, those countries were going to fall out of the model. So it took some work to identify and test different proxies for these factors. These are a few more details on the multi-level model. I'm actually not going to go into these in the interest of time. I will highlight that we did conduct validation exercises and simulations whereby we removed 20% of the data at random repeatedly. And the model-based estimates were close to the data-based estimates for those countries, in the final model at least. Here are some of the strengths of the model-based approach. One, it allowed us to use a lot more information than ever before because, as I said, we can now also use information on the predictors of abortion incidence. We were able, for the first time, to compute confidence intervals, which in Bayesian speak is uncertainty intervals around these estimates, so that now we could tell if the difference between country X and country Y was statistically significant. We were also able to use one data set to estimate trends over time, and that, together with the confidence intervals, allowed us to also assess whether trends over time were statistically significant in different parts of the world. And one thing that I'm really excited about, and this is coming out in the next month, is that we were able to make estimates for every country in the world with confidence intervals around all of those estimates so that we could be transparent about where we didn't have a very good evidence base for the estimates that we're making. So if I didn't already mention, and I think I didn't already mention, we're still working on describing this research in a way that's faithful to the information sources, which collect information using gender binary definitions, but also describing the results in a way that acknowledges the populations to whom they're meant to apply. So that part of it is still a work in progress. So here's some findings. We did find that unintended pregnancy is less common now than it was 30 years ago. And by the way, we can only estimate the incidence of unintended pregnancy after we've estimated the incidence of abortion, because unintended pregnancy is the unplanned births, but also the abortions and miscarriages of pregnancies that were unplanned or unintended. But we also found that the incidence of abortion hasn't really changed over these past 30 years. So these two findings together tell us that people who don't want to be pregnant are more likely to have an abortion now than they were 30 years ago. And now that we have estimates for countries, we can look at the rates in different groups of countries. And here we grouped them by their abortion laws and found that countries with restrictive laws, that's those on the left of this graph, had just as many abortions as countries with liberal laws, and that's those on the right. And here I've included the vertical lines that represent the uncertainty intervals to kind of drive home the point that these abortion rates are not different from each other. I also collaborated with WHO to estimate the % distribution of abortions according to their safety. And the incidence estimates are the foundation for the safety estimates. And I didn't get into the definitions of safe and less safe and unsafe abortions and the specifics of this model-based approach, but we did develop a model with a similar form as the incidence model, but with different content. And but I think it's really important to share this finding because it's part of the story that our research kind of grew out of our research. So worldwide, more than half of abortions are done under safe conditions. That's 55% on the top bar. But in countries with restrictive, very restrictive abortion laws, 3 out of 4 abortions are done under unsafe conditions. Whereas if you look at the middle bar, the third one up, in countries with liberal abortion laws, close to 90% of abortions are done under very safe conditions. The definition of how we count and classify abortions with respect to safety is evolving. I expect in the next couple of months, WHO will be releasing new guidelines for safe abortion, and in a year or two, these will hopefully be updated. Well, given WHO, maybe in 5 years. So while I've been working in the peer review academic model with a focus on publishing, it's the policy relevance of this work that has been rewarding and seeing it taken up in the policy discourse. And these are some of the forums where I've been asked to present evidence on my work. One of the most rewarding experiences was being invited to present this evidence to the Citizens' Assembly of Ireland that was charged with deciding whether to recommend a referendum on the abortion law in that country. Abortion was allowed only to save a woman's life. I ended up giving about 3 presentations in Ireland in that year in 2017. And it was really exciting and gratifying to be even just a cog in the wheel that led to the legalization of abortion in Ireland in 2018. This work also got a lot of pickup in the media, and I got myself trained on engaging with the media and ended up giving a lot of media interviews. And another of the rewarding experiences in the course of my career was being at a social event. And when I said what I do for a living, someone said, I heard abortion is just as common where it's legal as where it's illegal. And it felt like we had managed to move the needle a little bit in terms of the public discourse and hopefully evidence-based decision-making and voting. So I am going to pause there and take a minute to see if people have any questions of clarification, or at least have a moment of silence so you don't have to keep hearing me. And then I'll switch gears and talk about how we estimate abortion incidence at the country level.
There is one comment, Gilda, in the chat. Could you please talk more about your data sources? Do you use the demographic and health surveys?
Yes, okay, great. Yes, the demographic and health surveys are an important part of this. That's the source of estimates of the incidence of unplanned births. Like I said, the unintended or unplanned pregnancies are the sums of the births, abortions, and miscarriages of pregnancies that were unplanned. So those are a key data input. The other thing that made it possible to make these estimates was the work that I saw from the UNTD population division that inspired it also made it possible. They developed and published model-based estimates of the level of contraceptive prevalence and the level of unmet need for contraception for every country year, going back even longer ago than 1990, but I only went back to 1990. And those were the key predictors in the model. And we tried a few different predictors of, say, fecundity. Again, we needed it for every country and every country year, so that really limited us. And we tried a few different things, for example, the age distribution of women in the population. And those covariates, the predictors that were along the bottom of the conceptual framework, they ended up all falling out of the final model during a model fitting process. And we've talked about how that might be because our proxies were weak representatives of what they were meant to represent, or it could be because those relationships, their influence on abortion incidence was already manifest in the abortion data that we had.
Great. Anybody else?
Question on that? Yeah.
I would have a question. Thank you, Dr. Sedge. In your conceptual framework slide, you had the fecundity as a major input aspect. And I recall a recent discussion we had on lack of knowledge about male fertility, and also the discussion about how environmental factors may affect male fecundity and fertility. I'm wondering what you think about that aspect.
Yeah, you know, it's an understudied topic, and it kind of, in parallel to that, I'm working on generating the data that we need with respect to abortion incidence. We also need researchers generating data on that, on fecundity, on levels of infertility, couple-based measures or measures based on the woman in the couple. I can't say that it's understudied, and again, it's so understudied or that we were not able to put into the model an indicator that really directly spoke to fecundity, that really accounted for example, environmental influences on fecundity and how they might vary across parts of a country or parts of the world. Same with frequency of sex. When another piece of work I've done is to unpack why couples aren't using a contraceptive method if they don't want to get pregnant. And a lot of people say, we're not having a lot of sex. Whether it's true or not, we need to be, it would be great if we can get better information on this, on the experiences of and behaviors of people who are not using a method to help us establish whether they even need a method or not, and are we misclassifying people, and that affects our research and it affects our programs. So I'm digressing a little bit from the topic you're talking about, fecundity and infertility, but to talk about some of the data gaps more broadly. Yeah.
Do you want to keep going, and we'll, again, others could jump in, but
yeah, sure. So the global model needs country estimates, and countries need their own setting-specific research. That's the research that's most compelling in the country setting, and that's also how we can unpack and examine inequities within population subgroups in the experience of unsafe abortion, access to post-abortion care, et cetera. So as I described, service statistics are often incomplete, and abortion is often underreported in surveys. And so we've tried as a field different ways of improving the quality of abortion reporting in surveys. And we've had poor or mixed results. Some of our methods don't yield any contextual information, which I think is important on who are the people who are having abortions, are they safe, et cetera. One area of research that my colleagues and I have been pursuing is social network-based methods, where we ask a respondent about the abortions in their social network. And many of these are really sensitive, in particular to what we call the network generating questions. In the crudest of terms, if I were to ask you know, how many women of reproductive age do you know in New Jersey? And that's informs the denominator of the rate. And of those, how many have had an abortion? Our ultimate estimated rate is really sensitive to how many people you think about in that moment when you're telling me about the size of your network. So one of the approaches that I've suggested that's really a hybrid of approaches that already exist is the confidant method. And that's where we ask our respondent to think about two confidants in who confide in her, in the respondent, and in whom she confides, and ask about the abortion experiences of those two confidants. So now we're kind of fixing the size of our respondent's social network. The advantages include that it increases the effective sample size over self-reporting. We can get some contextual information on the circumstances of the person who had an abortion to the extent that our respondent has that information. And we can, I'm going to try not to go into too much detail, but we can adjust for lack of transmission of secrets between the respondent and her confidant if we assume reciprocity. Among our respondents who have tell us that they've had an abortion, we ask them, did you tell your confidant about that abortion? And we assume that she's as likely to have told her confidant as her confidant is to have told her. Questions? Happy to go into that a little bit more. I, with my colleagues, have tested this method in Indonesia, and other colleagues have applied it in the study of abortion in Cote d'Ivoire and Nigeria and Rajasthan. But there are a lot of outstanding methods. It's still a work in progress. For example, we need to establish that women who have abortions have the same social networks as women who don't, and so that they are equally likely to show up in our research. So far from all we know about the characteristics of people who have abortions, they do. It's regular people having abortions out in the world. How can we capture the abortions of people who don't have any confidants and who therefore won't show up in the sample of confidants that we generate from our survey? Another question that I think is increasingly important is, can we use this approach to learn about self-managed abortions, which are becoming more and more common, both safe and unsafe self-managed abortions? And something I'd really like to do is test this approach in a setting with good data. And that takes me, that's my shift to the future work that I'd like to see and that I foresee doing in the future. And they fall into two broad categories. One is continuing to innovate on these methods and test them. And the other is on generating more knowledge on abortion and unintended pregnancy. So I think the time is right to test social network-based methods in the US, in states in the US, where we have good data on abortion incidence, thanks to my colleagues at Guttmacher and to colleagues at the CDC. And I would also like to use these methods or identify potentially other social network-based methods and identify the best ones for studying self-managed abortion. It might be the confidant method, it might be respondent-driven sampling, it might be the starfish method that I think colleagues at Rutgers Global Health studying LGBTQ health have spearheaded, which is like a hybrid of pre-existing methods also. And I think we can really benefit in a synergistic way by testing these methods to study more than just abortion, to study other clandestine behaviors too, and we can learn from each other. With respect to generating new evidence, I want to bring these methods to the study of abortion in the US, not just for methodological reasons, but also when Roe falls and states restrict their abortion laws, the decisions will be made at the state level. We will need methods to study illegal abortions that happen outside of health systems in the US. We will continue to have good evidence on abortions that happen in health systems, fortunately, in this country, because we will have that infrastructure in place. And then I do want to continue to extend these methods as we improve them to the study of abortion and other clandestine behaviors in low and middle income countries. And when I say other clandestine behaviors, touching on the question that I just got from, I think, Dr. Schwander, studying infertility and the couples' behaviors in the face of infertility, that being a stigmatized experience in a lot of these settings. And I also would like to extend these, as I have in the past, but to studying inequities and access to safe abortion and the experience of unintended pregnancy. I've studied these events in adolescents. I'd like to study them in migrant and immigrant populations as data allow, and there are data for that in a number of countries, including in European countries and in the US. And lastly, I think this is my last real slide. I am really interested in pursuing new models for engaging with our research partners, accelerating the dissemination of research. I'm a co-chair, as Dr. Marling described, of a learning collaborative, whereby we are about 200 researchers and non-researchers from across the globe who study and use evidence on self-managed care in sexual and reproductive health. And these are opportunities for us to disseminate our findings in real time and be informed by experiences on the ground. And related to that, as Dr. Marling also said, I'm developing a research agenda on self-managed care and centering there the priorities of stakeholders who would use this evidence in the global south. And depending on the research questions that we're addressing, I think it's a model that I'd like to see us elevate is developing research agendas that center on the users of that research. And I think probably a lot of people here are engaged in discussions about how we shift power and how we become responsible for the decolonization of global health research. You know, I was a PI on those studies of abortion incidents in Senegal and Burkina and Indonesia, and I shouldn't be. Going forward, I definitely shouldn't be. And we have to adapt, for example, our metrics for success so that they're not me being a PI, but they're me building capacity. For example, providing technical guidance, having first authors coming from the countries where the studies are happening. So those are some of the conversations that I'm sure people having here that I'm really keen on pursuing further and turning into concrete action. So this is my last slide, aside from my thank you. This is the takeaway, some of the key takeaway messages. I hope I've demonstrated that abortion happens everywhere, that it's not going away, that it's hard to study and we need to keep innovating on our methods, but also that it's important to study, that evidence on abortion can inform laws and policies. So have I left time? I think I have left time for discussion, and I'm looking forward to that.
I think it's a good time to also give you a round of applause, both with the little emoji and the real thing. Thank you so much. As we're likely entering an era in the United States with more restrictive laws, regulations, this is, as you point out, going to be all the more important to figure out how to study it and how to influence policies and laws with real data. And so let's open it up. Ashley Grosso, you also had another comment. Maybe do you want to jump into your interesting comment about other similar challenges that you and others are having?
Sure. So when you were talking about the, the question, how many women of reproductive age do you know in New Jersey? We have also struggled with this using the network scale-up method with female sex workers and men who have sex with men, mostly throughout Africa. And more recently, we're thinking about this for a cohort study with immigrant adults in the US, particularly when we're talking about undocumented or other stigmatized populations. So I'll be really interested in those methods you've been talking about and how you can apply it to other groups and issues. And just one comment on, I completely agree with you. There are some studies that I wish I wasn't the PI and somebody locally could be, and we've tried to do a lot of capacity building. I think in academia, it's a little bit challenging because we're supposed to be the PIs and bringing in grants and leading things, but I think there's a tension there with the wanting to be supportive of communities. So just a comment on that and welcome any thoughts you might have.
Thanks. I'm really glad you brought up all of that. Those are speaks to how this is a really good environment for this kind of work. My colleagues at Guttmacher have also used and tested the network scale up to study abortion incidents in Uganda and in Ethiopia. And I've plus and negative. On the plus side, that's where I got the reciprocity piece for the confidant method. They had developed that. And so I'm really glad that they worked on it and are working on it. And that's one of the examples of how we can exchange insights across different methods and possibly cross-subject area, which you also brought up. One of my reservations about that approach is that we don't get information on who's having those abortions. We just get a number. And I think it's really important for us to understand who's having unintended pregnancies, how safe or unsafe are the abortions that they're having, what is their experience of stigma, to the extent that we can get that as well, because that's a health issue as well. I wouldn't necessarily dismiss it all together. I have thought about whether I think we should dismiss the network scale-up method altogether, because I think that's critical. But it may end up being that, you know, we get our estimate of incidence from the network scale-up, and we get our characteristics of people who are having abortions from confidant, and maybe we can apply both of those approaches in one survey. You asked about the other populations. Yes, and like I said, I saw, I can't remember his name right now, someone at Rutgers who's used these methods to study hidden populations. So it's different from clandestine behaviors, but there's a lot of how those two studies can speak to each other. And what we do about our metrics of success and our models for working, you know, I've been very guilty of thinking in the course of my career, my life, that things don't change. But then you live long enough and you see that things do change, they can change. And so the discussion and discourse is one of the steps in that direction. That's as far as I'm going to go in trying to solve that problem in the course of the remaining few minutes.
Thank you.
Yeah.
Well, the increased use of multi-PI and co-PIs and has helped somewhat, I think, for that setting, but it's not by any means a total solution. So yeah, I guess maybe you're talking about Henry Raymond. I don't know if he's not on. Yes,
that's what it was.
I didn't know.
Yes.
I was prompting a couple other people.
Hands raised. Yeah.
Yeah. So anyone else? Oh, I see Marilla. Yeah.
Hi. I enjoyed your talk a lot. I have a couple of questions. One is with this direction that you know, the abortion discourse is taking in the United States toward, you know, some restrictive laws, etc. What changes in policy? I don't know if policy is the right word, but what approach or what approaches could be taken by advocates of abortion or you know, freedom of choice for women that haven't worked or may not have worked in the past? So is there any new ways to approach the problem to address, not to address, but, you know, to counter some of this, you know, a trend toward this restrict? Of course, some of them will be resistant to any argument, but is there anything? That's one. The other thing is, you know, we're been you know, 2 years into this pandemic, and how is the, you know, how does your work how is your work affected by, say, the pandemic, or how do these studies or the or how abortion or the frequency or the approach or whatever changes during these, you know, global events that could be the pandemic or war or, you know, these big events?
Thanks.
Thank you.
Those are big questions and important ones. Thank you. One of, with respect to how we can advocate for keeping abortion legal or making it legal again when it becomes illegal, like I think you acknowledged when you were asking the question, there are decision makers in power at times whose decisions and policies are not informed by evidence. And there's not a whole lot we can do to change that. We can prepare ourselves. We had an administration that had absolutely no interest in evidence, but we used that time to prepare ourselves for when we had an administration that was interested in evidence-based policy. So we have to play the long game. We have to generate evidence so that when those who want to use evidence are in power, they have the evidence that they need. What the framing is, I think it's really useful to have cross-country collaboration on what worked in this country, what worked in that country. There isn't one formula that has worked across countries. Sometimes it's having a national champion who has a lot of charisma and who has the pulpit. Sometimes it's really compelling evidence on maternal mortality and how high is abortion-related maternal mortality, and having people in power who are interested in moving the needle on that. So there isn't one formula. I think in Ireland, having people in Ireland being able to see themselves in the context of the laws in developed countries was a powerful piece of evidence. And in the US, perhaps seeing ourselves in the bigger picture as well. It's just one framing that can potentially be useful and powerful. I'm remembering now that you also asked about the pandemic and how that affects our work. One way is that in England, for example, the provision of abortion drugs through telemedicine became legal and allowed. And it was a wonderful natural experiment in that it allowed us to really see very clearly that medical abortion through telemedicine is perfectly safe and reasonable and doable. There's some movement in that direction in this country. In some states, telemedicine for abortion is allowed. And I think that the pandemic has opened our eyes to what's reasonable and provided evidence in support of it. It's just one example.
Thank you.
Mm-hmm.
Yeah, Leslie.
Gilda, nice to see you. This is actually a good question for me to come in on because I've made the mistake of having New York Times alerts on my phone. So I saw the Florida vote at about 2 in the morning and I was up the rest of the night. So, but I'm not going to ask you another advocacy question. What I would love for you to talk a little bit about is, because this work is stigmatized, not every funder rushes to fund it. And yet you have a very, very successful track record. So I wonder if you could just talk about some of the sources of support for your work.
Yeah. For this kind of research, global abortion, the real support for this work comes from the European country governments. More so from the US. And I've been fortunate to be able to get support from the Dutch and from Sweden and the UK. And they are real powerful drivers and they've kind of moved from the back seat to the front seat, for example, with respect to funding of UNFPA and getting UNFPA to take on the issue of abortion for the first time. So that's where the competitive and healthy sources of funding are on this work. And one of the things was very excited about doing this year as an advisor for SIF. It's a foundation based in London that also was established by a very wealthy man. We're familiar with those kinds of foundations. I interviewed the program officers of the major donors supporting global safe abortion to identify their strategic priorities going forward. The purpose was to help SIF find its place, what its value proposition is, but it's been a wonderful opportunity to get a sense of which parts of the world are being prioritized, which of the funders are particularly interested in evidence to support advocacy. And I knew most of those program officers anyway, but that's been a great experience that I hope to be able to take advantage of going forward. And I do think that NIH is potentially a source of support for the methodological pieces of this work, especially as we extend it to study other behaviors. Thanks for asking.
So Dr. Fredericks James has an interesting question. I was wondering too in the chat. Does she want to unmute, or do you want me to read it for you?
Do I know whether data have confirmed a relationship between maternal mortality and legal status of abortion? Yes, and it's been tricky. There have been attempts over time by those who are opposed to liberal abortion laws to demonstrate that we have low mortality rates in countries with restrictive laws, for example, in Chile. That was largely, cherry picking a couple of countries that are exceptions because they are wealthy, economically well-developed, but have restrictive laws. More recently, there was an ecological study that looked across countries. And even though it was ecological, was able to control for a couple of the potential confounders that, yes, demonstrated a relationship between restrictive laws and a high level of abortion-related maternal mortality.
Okay, I'd just like to come in there. Thank you. Thank you very much. I guess you're not hearing me very well?
Yes. I'm going to concentrate and then I will, yes.
Yeah, I asked that question because, like I said, it's at the back of my mind, but also I'm thinking of my time as a clinician. I can recall seeing during my practice women who came in who had abortions outside of the health sector and really suffered, the consequences. And I'm actually a bit concerned for the US because having more restrictive laws, as you've indicated, it's not going to, women who really want to have an abortion will try to get one. And if they can't afford to travel to another state, somebody else, somewhere else, will be providing a service and they'll be at risk. So thank you so much.
Yeah, and I think the US is a case where we can, to a limited extent, borrow from experiences of other countries to predict what's going to happen, but we're so different from most of the countries with restrictive laws. You saw they were largely in Africa and Latin America because, one, we're a developed country, two, we've had legal abortion for all these years and that infrastructure is in place. Three, medical abortion, telemedicine is perhaps becoming more widely available coming out of the pandemic. So we don't know, are people going to continue to have safe abortions? Are they increasingly going to have unsafe abortions? Are they increasingly going to have births that they don't want to have? It's really, we don't know. But those real life experiences that you just described, Marlene, Dr. James, are also really powerful, and they're just as powerful, sometimes more powerful than 70 million people around the world have had an abortion. So thank you for the question.
Yeah, Devin,
yeah, go ahead.
Yeah, no, my question was, I know that some of the South American countries that have started to remove or have removed abortion restrictions, if there's opportunities for natural experiments on the effects on infant maternal mortality.
One of the things that it's really hard to do a natural, perhaps yes, on the outcomes that you just talked about, it's hard to do a natural experiment on the impact of laws on incidence. I mean, we have the model-based estimates have helped, but when it comes to one particular country, when abortion is illegal, we don't tend to have really good estimates, and we don't tend to have estimates that are comparable to those that we get when in a setting where it's legal. So it's really hard to get a good before and after the data. So there have been times when abortion law has been liberalized and people point and say, look how much more common abortion is. And other people say, it's not more common, you're seeing it now in the records where you didn't see it before. But for some of the outcomes that you described, if they're common enough in relationship with unsafe abortion, I think that's a really good idea. So fun to get to talk about the things that you love to talk about. I welcome any other questions.
Well, this is the group that's here because they're interested. So anything else? Anybody else want to jump in before I ask Gilda to jump in and say her her last comments or and then also to say her thank yous, because I'll thank you right now, Gilda, for coming and for giving the great insights of your work and where it's headed and how it's important now, especially here at home. But thank you so much. And do you want to give any comments to us?
I really appreciate that the questions are the thoughtful questions and comments, and that some of them do kind of elevate the issues that I think we're all facing. How do we learn from each other who are studying different things, and how do we use what we're learning, and how do we kind of change how we're learning, especially when it comes to global health research. So thanks, it's really great kind of meeting some people here who I hadn't met before. I look forward to more conversation.
Great.
Thank you.
Yes, thanks.
Thank you.
Thank you so much for coming, everyone. And yeah, I'll reiterate the applaud. Thank you, Gilda.